चल नहीं रहा. When we were talking about the diabetes overview, we covered the etiology and monitoring of a diabetic patient and the diabetes itself. Is about the management of different types of diabetes that we have been speaking about last time. Now, I'm going to be discussing on the treatment of type 1 and then type 2 diabetes. I'm pretty sure most of you are aware of the fact that in the last decade, the management part, the therapeutic management part of diabetes has taken a very, very big stride. There have been many new drugs which have come up in the market, and those are the kind of drugs which I probably will be touching over this period of time. Now, starting from what our objectives are, and the first objective is that what is our guideline of achievement, advisable levels that we would want our patients to be on is a glycosylated hemoglobin should be less than 6.5, a fasting blood glucose of less than 110, and 2 hours postprandial blood glucose value of 145. This is what IDF, International Diabetes Federation, recommended in its guidelines last year. Before we really achieve these subtle figures which I have mentioned, there are certain things which I would like to emphasize, which I have been repeatedly saying, that we should not be treating the laboratory. It's the human being who has diabetes that we are treating. So the first thing that we must keep in mind, that whatever we are trying to teach a diabetic to follow, it basically is a healthy lifestyle. We are asking that diabetic patient to eat a healthy kind of food. We are asking a diabetic patient to walk around, do some exercise, which is very healthy. Practically, whatever we are treating or whatever we are preaching to a diabetic is essentially a very, very healthy form of lifestyle. The person who is a diabetic, we should not put on a stigma that this patient is diabetic, so it's a doomsday for this patient. That patient, by all definitions, is a normal person with some restriction in his or her lifestyle. They have to restrict their diet. They need to do some exercises, and the only difference between a normal and a relatively, in inverted commas, abnormal person is that they need to take some medicines which they continue for probably the rest of their lives. Diet, discipline, and drugs. If you keep a close watch on these three things, a patient's diabetes is invariably almost under control. Now, one of the important things which I felt I should mention today is, do not criticize when a diabetic patient is doing something wrong. That is a very important point. For he or she knows that there is something wrong which they have done. But one thing which I emphasize that we must, as doctors, should do is that we should never forget to appreciate if that patient has done something right. We must give some credit to that patient that he or she is doing what is right. Now, every diabetic patient has to pass through different psychological states. State of shock, a state of fear, a state of venture, rebellion, and regret. These are identified psychological states which each diabetic patient has to go through. Now, when a patient comes to us, we should never forget to identify which stage of mind that patient is. Because whatever advice you are going to give to that patient is primarily dependent upon whether that patient is shocked, in a state of shock. It's a bad news. You tell somebody he or she is a diabetic, it's a bad news. Whether that person is scared, he or she probably has seen a lot worse than you and me has seen as far as the diabetic patients are concerned. State of venture, rebellion. They have to rebel at some point in time to whatever you ask them to do. And finally, when the complications start, they usually regret and they get into depression. And these are the stages that, if identified, your diabetic patient can be very well controlled and is going to comply with whatever instructions you are going to tell to this patient. Now, how should we treat them therapeutically? For insulin-dependent diabetics or type 1 diabetics, we usually have injectables. So I thought I'll just mention there are two forms of injectables available for the management of diabetes. The first one is insulin, we are all aware of. The second one is what we call exenatide. Now, exenatide is a molecule which I'm going to, or is a drug which I'm going to talk about just in a few minutes. Starting out with insulin, we know there are different types of insulins. There are different origins of insulin, but nowadays, because of recombinant technology, we have got an insulin molecule which is exactly similar to what a human person produces in his or her pancreas. Their difference depends upon what the duration of action of this insulin is. There are ultra short acting insulins, which is the Lispro insulin. Then we have short acting or soluble insulin, which is the regular insulin, the intermediate acting insulin or NPH insulin. We have a flat action insulin, which is called glargine insulin. We have inhaled insulin, which is called Exubera, and we have a premixed or biphasic insulin, where regular is mixed with NPH in different proportions, 30-70, 40-60, 50-50, 90-10. So different proportions of regular and NPH constitute what we call biphasic insulin, and then we have insulins for CSII. Now, what has also developed in the recent past is the mode of delivery of this insulin to the patients. Insulin syringes have become very fine. The injection today is much less painful than the injection which was 2 decades ago. We have CSII, which is continuous subcutaneous insulin infusion pumps. We have pneumatic injectors where a vacuum or the air thrust is going to push the insulin molecules under the skin. We have pens and pen fills, which is very convenient for people who are traveling a lot. And finally, we have now insulin inhalers available for us to deliver this insulin. Now, as I mentioned, that the difference between different types of insulin is primarily dependent on their duration of action. The short-acting insulin starts in about 20 minutes to about 0.5 of half an hour. It can reach its peak between 1 to 3 hours, and its action practically finishes after 8 hours. So it is a kind of insulin which has got a shorter lifespan. Then we have the intermediate acting insulin, or NPH, which has got an onset in between 1 to 3 hours. Its peak effect can be seen at 4 to 8 hours, and finally we can see the insulin coming off the system in about 14 hours time. Long acting or ultra-lenti insulin starts its action at 3 to 5 hours, has a peak effect on 4 to 8 hours, which is more or less like the intermediate acting insulin. But what is important in this one is that its action can persist for almost 28 hours. So probably this is a type of insulin which remains in the system for the whole day and night. How we should advise our patient and make a dosage for this patient. The question that we must be asking to ourselves is that we should be giving the insulin which is akin to a normal physiological pattern. Now, what is a normal physiological pattern? The normal physiological pattern of insulin secretion is that whenever we take some food, the food gets absorbed. This absorption of food is going to have an outburst of insulin. The sugar goes down. The body senses that the level of sugar is down, so the pancreas shuts down and goes down to its basal level, and then there is again an upsurge with the next meal. Now we have to devise our injection strategy according to whatever happens in this normal human individual. In this situation, the best is that we calculate how much insulin is required by an individual. Mind you, it is calculated on the basis of 0.3 to 0.7 units per kilogram body weight. That is what is the recommended dose calculation. At this point in time, I would like to make another point, and that is these calculations may be very different because they are very much dependent upon how much resistance to insulin every individual is having, and we all know that each individual is going to have very different form of insulin resistance. But the rule of thumb is that between 0.3 units to 0.7 units per kilogram is how you calculate the initial dose of insulin. 2/3 of the dose is given with the breakfast with the regular and NPH ratio of 1:2, and 1/3 of the dose is given in the evening with the same ratio. In situation where we are giving a premixed, which is 30/70 insulin, then we usually give half the dose in the morning and half the dose in the evening. The side effects that we keep in mind whenever we are monitoring and advising a patient to take insulin are hypoglycemia. That is by far one of the most important and significant symptoms that a diabetic patient is going to be told about when you are going to advise this patient to take insulin. Local allergic reactions, weight gains, local fat atrophy and hypertrophy are the other things which probably at some point in time when you are managing and treating your diabetic patient should be informed to that particular individual. Lispro insulin is a synthetic insulin. It has got a very rapid onset of action. It has got a very short duration, and this is useful in those individuals who get a postprandial hyperglycemia, and within 4 to 5 hours they get a rebound hypoglycemia. So in those situations you really don't know what kind of insulin you are going to use, because regular and NPH combination is going to get you nowhere. These patients bounce whenever food is taken, and a few hours later they just go into hypoglycemic episodes. In those individuals, the ideal insulin that you can use instead of regular insulin is a Lispro insulin. Short-acting insulin, I already have talked about that there is a peak action of 1 to 3 hours, and it is given just before meals. The concept of waiting for a little time does not imply when we are talking about insulin injections. Intermediate acting or delayed acting insulin, their duration is somewhere around 8 to 12 hours, and they need to be mixed up with the regular insulin to cover the postprandial upsurge of blood glucose levels. Premixed or biphasic insulins are actually made for the convenience of the patients, that instead of patient drawing the regular and NPH insulin, the already mixture is made for the patient to draw the required units of insulin and can immediately inject himself or herself. And 3070 is the only insulin which government of Pakistan has permitted to be imported in this country, but outside world we do have other types of insulins, and you can give the insulin according to what that patient's requirement of regular and NPH ratio is going to turn out. We usually give 2 injections. One is given before breakfast and the other one is given before dinner. We expect that our NPH is going to cover our lunchtime upsurge of glucose levels. However, saying this thing, we may have 2 important categories of diabetic patient. One of them is a young brittle diabetic where the blood sugar just sparks off and it falls down very rapidly, and the other is a patient who is pregnant. Now, pregnant diabetics is a special group of diabetic patients where we have a very, very narrow margin of glycemia that we have to cover. So in these sort of situations, 2 injections may not be enough to control the blood sugar fluctuations. So in those sort of situations, we may get into a 3rd injection of a regular insulin, which is given with the lunch time. Continuous subcutaneous insulin infusion pumps may be used, particularly in young diabetics who want to lead a very free life and more independent life, giving them a better opportunity to live a proper life. Premixed insulins, as I said, are given in pen injections as well as in syringes, but the pen injections are helpful because of the convenience which it confers to that particular patient. It's the same thing. The Lispro is given for the brittle diabetics who have a postprandial hyperglycemia. But saying this thing, Lispro is one of the insulins which has come out in the last 1 decade. The other insulin which has come up and which has really revolutionized the management of diabetic patients, both type 1 and type 2 diabetic patients, is an insulin which is called glargine insulin. It is also known as flat peak insulin. This insulin does not have a peak. It has got a flat action. And this action is going to achieve a baseline insulin levels for the whole 24 hours. Now, if we have a basal insulin being taken care of glargine insulin, we only need to cover the postprandial hyperglycemic upsurge in the blood sugar levels. 1 injection is sufficient to augment the insulin levels in a type 2 diabetic patients, where we can use a glargine insulin once for 24 hours and use oral hypoglycemics if there is a sufficient insulin reserve in the pancreas for the management of type 2 diabetes. Now, insulin pumps, they used to be very heavy pumps when the whole thing started in 70s, but they have now become very smaller, very sophisticated, and very reliable. Sophisticated in the sense that some insulin pumps actually have sensors to sense what the blood glucose level is, and they can continuously monitoring the blood glucose level, and accordingly you can program these pumps so that the required amount of insulin can be given to that diabetic patient. They are usually used by children, adults, and both for type 1 and type 2 diabetics. They deliver insulin And usually nowadays, because of the advent of new needles, they are more reliable. I remember the days when they started on. We used to have a hotline for those patients who were put on CSII, because at some point in time the pump was going to stop functioning and the patient could go into crisis not knowing what to do at that point in time. But that kind of problems no longer exist nowadays because of the development of these sophisticated pumps. Also, it helps the nocturnal and activity related hypoglycemic episodes, because the pump senses what the blood glucose level is and accordingly can change itself. Now what happens is you just wear it like a Walkman on your belt, and they can be put under the clothing, and a small needle is given subcutaneously in the abdomen. The dose is entered into the small computer of the pump, an appropriate amount of insulin is injected, which is calculated by the pump itself. Now what happened was that early this year, on 27th of January 2006, this was a very important news that FDA approved the first ever inhaled insulin for the treatment of diabetic patients. The phase 3 trials of inhaled insulin started some 2 years ago, and there were a lot of problems in form of type of insulin which was to be used and the mode of delivery of the insulin inhalers. But the whole controversy was cleared, and the drug called Exubera was approved by FDA in this January 2006. Now what happens is, it's a special form of insulin which the person inhales like we inhale the Ventolin or whatever inhalers. And usually the action of this insulin is more like a short-acting insulin. The studies are very, very promising, and there are a few good studies which indicate that yes, this insulin is more effective, more convenient for the patients. The only problem which this study showed, that there is a decline in the lung functions of an individual. The FEV1 and DCO ratio in 1 year is doubled as compared to a person who is normal and using subcutaneous insulin. So there is a problem that it is going to affect the lung functions of the individual. So there is subtle recommendation that we should only advise this form of insulin in people who are non-smokers, and it is important that if those people who are smoking should be switched on to nicotine pump, because the last cigarette is going to affect the absorption of insulin. It is the other thing which came up as injectable is a new group of drugs which is called incretins. Now this exenatide is an injection which resembles incretin. This is a hormone. Now what happens is that whenever we take food, as it goes into the stomach, the senses start the secretion of insulin from the pancreas. This is what we call the first phase of insulin secretion. In diabetic patients, this phase of insulin secretion is definitely impaired. Now that is where this molecule comes up. It normalizes the loss of first phase of insulin secretion in patients who are type 2 diabetics. Not only that, it also helps in slowing the gastric emptying, and with the result, the satiety of an individual is improved, because all those people who are fast eaters and their transit time in the stomach is less, they tend to eat more. Now that is where this exenatide comes into picture. It can be thought of having the same benefits as the secretagogues of insulin plus a biguanide plus alpha glycoside inhibitors without really producing a bag of hypoglycemia, lactic acidosis, or flatulence, which are the side effect of these three drugs that we talked about. It's a subcutaneous injection which is given before and after in the evening and in the morning, and comes up as 5 to 10 microgram per dose pre-filled injection device. Now, FDA again has approved exenatide only this year as an adjuvant therapy to improve the glycemic control for patients who have type 2 diabetes and who have not achieved an optimal control with metformin and or a sulfonylurea combined with metformin. It can also consider it as a monotherapy for the management of type 2 diabetes, but at this point in time the FDA approval only stands for those patients where an optimal control is not achieved by using the maximum doses of oral hypoglycemic agents. Let me get down to something which is also a very novel idea, and that is that if we are going to take out some islets of Langerhans and then transfuse those islets of Langerhans to an individual, we probably can generate a new pancreas in addition to an old and non-functioning pancreas of a diabetic patient. Now, this led to a lot of work being done for the islet cell transplantation. The important thing is that we need enough islets to be given to an individual for producing an optimal sort of an effect. 1 million islets are needed for achieving this objective, and you may need 2 donors to provide those number of islets. The main problem with any form of transplantation is that a person can reject this, and rejection still remains one of the main problems of islet cell transplantation. Islet cells usually are not transplanted as an isolated transplant because of the problems related to rejection. So it usually is considered as an additional transplant to a patient who is receiving another organ for something else, like it's a part of a kidney transplant operational procedure, or a heart transplant, or a liver transplant. So if anybody who is receiving these organs can have an additional islet cell transplantation as well. They are infused through a catheter into the liver under a local anesthesia. The procedure of islet cell transplant is pretty simple. It is the retrieval of the cells which sometimes is important. The islet cells will attach themselves with the blood vessels and they will start functioning wherever they are. They probably may be staying in the liver and they may be starting to produce insulin, producing a normoglycemic effect of insulin. Now, in 2003, 50% of the patients who were transfused remained insulin free for up to 1 year after transplant. And this seems to be a reasonably good response, especially when the number of islet cell transplants aren't very many as compared to other organ transplantation. Now, with this I come down to the second part of my talk, and that is the treatment of type 2 diabetes. Now, we have got the whole list of drugs and groups of drugs that we can use for the treatment of type 2 diabetes. We can start with sulfonylureas, and probably sulfonylureas were the first drugs which were used for the treatment of type 2 diabetes. They stimulate the insulin secretion and they are useful for people who are non-obese. Now, the word non-obese is important because most of the time that we talked about the non-insulin dependent diabetic is an obese individual. We started with acetohexamide, then chlorpropamide, tolbutamide, but now we have got a better generation of sulfonylureas like glibenclamide, glipizide, and gliclazide. Now, these drugs are good because they have a relatively short half-life and they do not have those hypoglycemic effects or severe side effects which the first generation of sulfonylureas have. Non-sulfonylurea secretagogue is a group which has come up in the last 2 decades, and this improves the postprandial glucose upsurge in an individual. And the drugs that we use is repiglinide and neteglinide. These are the 2 drugs which practically have the same kind of effect as sulfonylureas, but they do not have the side effects which are attributed to the sulfur molecule of sulfonylureas. Bigonides have been there for over 5 decades, and they increase the insulin action, or they are used as insulin sensitizers, as what we call them today, and they are usually useful for obese individuals rather than thin and lean person. Metformin is the drug which is commonly used now. Fenformin had been taken off the market a few years ago because of the side effects, some lethal side effects which those drugs can produce. Alpha glucoside inhibitors, they inhibit the disaccharidase enzymes in the gut, with the result the disaccharidase is not going to function, the glucose is not going to be produced, and most of the carbohydrates can be excreted really without much of absorption. But the problem with this is they can have very nasty side effects. The model drug is acarbose in this particular group. Thiazolidinediones, or TZDs what they call today, is one of, again, new concept of drugs which started on with the advent of a new molecule which we call PPARs, alpha, gamma, and delta, and they are the one which sensitize the tissues to the action of insulin. They are insulin sensitizers. They can be used as monotherapy, or they can be used adjuvant to the other oral hypoglycemics that we may be using to our patients. Troglitazone was the first drug of this group, TZDs, but unfortunately that particular drug had a lot of liver side effects, hepatic side effects were there, so it was very quickly withdrawn from the market. Nowadays we have got the 2 drugs, rosiglitazone and piaglitazone, which are functioning and they are being practiced in most of the parts of the world. Insulin can be used for non-insulin dependent diabetic patients, and a combination therapy for patients who do not respond to oral hypoglycemics, that you combine the insulin with them, with the oral hypoglycemics, can also be a part of your strategy for the treatment of type 2 diabetes. What should we do? How should we proceed if we find a non-insulin dependent or type 2 diabetic in our clinic? The choice of initial therapy is based on the degree of hyperglycemia, the characteristics of the patients like BMI and age, other medical conditions, especially the renal and hepatic disease, and patient's lifestyle and preferences. Now, these are the 4 factors that we need to keep in mind whenever we are going to start oral hypoglycemic agents to any type 2 non-insulin dependent diabetic patients in the first place. Now, I started on with some recommendations that how should we be proceeding when we find such a case in our clinics. A typical patient with type 2 diabetes is usually obese and will present with minimal or no symptoms of hyperglycemia. And that is one of the things which we all have seen in our day-to-day clinical practice. In the presence of normal renal, hepatic, and cardiac function, metformin is generally considered as an initial drug for all those obese patients, and this recommendation is based on the UK PDS study which gave its recommendation in early 90s. Now, metformin not only polishes the insulin, it also affects as far as the obesity is concerned. It is one of the mainline drugs when we are talking about insulin resistance in an individual, and as we talked about last time, that for a type 2 diabetic patient, the bottom line is that this patient has most of the time increased insulin resistance as the cause of his or her diabetes. However, saying this thing, metformin is contraindicated in patients with renal insufficiency. Whichever patient we start metformin, it is obligatory that we should be looking at the renal functions as we see the liver function in a patient whom we have started the sulfonylurea. But for metformin, it becomes even more important because there are certain contraindications which are given, and if the creatinine is greater than 1.4 milligram per deciliter or 1.5 milligram in males, or there is a significant hepatic disease, or the patient has significant congestive cardiac failure, try to avoid metformin in those individuals. Age-related decline of renal function should be kept in mind because it is the elderly patients who get into the complications and who led to the cancellation of fenformin from the market by FDA because of lactic acidosis, which was lethal in those individuals. Insulin secretagogues are recommended for patients who are lean, have a mild renal insufficiency or congestive cardiac failure, or have a very significant symptoms of hyperglycemia. So these category of patients who have these problems as their main presenting features are the candidates for insulin secretagogues, whether that be sulfonylurea group or non-sulfonylurea secretagogue. That is immaterial, but they can benefit most from a secretagogue therapy. It depends upon the dosing schedule, relative risk, and insurance coverage. Now, here in this part of the world, the insurance coverage is the wallet of the individual. If the person can afford to have non-sulfonylurea secretagogues, yes, but if there is a question of the compliance because of financial reasons, then probably one of the sulfonylureas is as good as non-sulfonylureas. The sulfonylureas most cost effective are glipizide, long-acting one, not the short-acting one, glyburide and glimepiride, and they are all effective as once daily preparation. Thiazolidinediones or TZDs have a gradual onset of action. So you should not be expecting an immediate result whenever you start a TZD to an individual, but the good thing is that they keep on progressively increasing their efficacy as the time goes by, with the result that the initial treatment of type 2 diabetes should be reserved for those patients who do not have the symptoms of hyperglycemia, because the time frame that you are looking for is a little bit longer as compared to sulfonylureas. They may supplement the metformin, they may be used in addition to other drugs which I am going to talk about, but one of the things which is important is that they do have a problem with weight gain and a problem with fluid retention. Now, fluid retention is one of the most limiting factors that you could see in the usage of TZDs, because if there is a patient who has congestive cardiac failure and is on a balanced sort of a compromised state, can go into a decompensation, and similarly a patient with renal problems can go into the same sort of problems. Alpha glucosidase inhibitors have a modest effect on HbA1c, which is our yardstick to measure how efficient our hypoglycemic agent is. They lead to a lot of gastrointestinal side effects. Flatulence is one of the most common side effects that you would see in a patient whom you have prescribed acarbose, and that is the limiting factor in continuation of these drugs for these people. Now, I was asked this question last time, and I said to them that to the colleague that I'm going to address this question in this talk. Can a type 2 diabetic patient escape insulin? Now, that is a very vital question. The answer to it is no. At some point in time in our life, if we live long enough, the pancreatic cells, the beta cells, are going to fail. And once the beta cells are going to fail, then the only thing which can control the glucose in our systems is an exogenous insulin. So by far, any diabetic patient who is not controlled on oral hypoglycemics, we should not be very reluctant in initiating insulin to those individuals. We have a taboo in our community. Insulin means end of life. It is not. Insulin means a disaster. It is not. Insulin means that I am going to be whatever. It is not. Insulin is going to be an ultimate fate of a diabetic patient. Whether that fate comes earlier or later, that is just an academic proposition. There are subtle recommendations when you should be starting insulin in a type 2 diabetic patient, and they say that if the glycosylated hemoglobin remains greater than 7.5 after the maximum use of oral hypoglycemic agents, you are justified to start insulin in those individuals. Metformin, sulfonylureas, alpha glycosidase inhibitors can be continued in these patients, particularly with the development of this flat action insulin called glargine. There is a more and more consensus that we may be using oral hypoglycemics during the daytime and can give a glargine injection during the night time. Basal insulin, preferably glargine, is used. Now, sometimes glargine is a very expensive insulin. The cost can tether the individual from using this insulin, so NPH can be used as a second best drug for these people. Twice daily pre-mixed insulin, which is the biphasic insulin, or multiple injections can be used if the control of this diabetic patient remains suboptimal, especially when we need a mealtime flexibility for these particular patients, and especially the young type 2 individuals are more and more in these categories. The recommendations last year have been start the oral glucose lowering drug if the lifestyle modifications do not achieve the desired blood glucose level. Start with metformin, gradually titrate the dose until and unless we have a limitation because of the GI side effects or the impairment of kidney function in these individuals. You can use sulfonylureas if metformin is not achieving the desired target, or it can be used as an initial therapy for those people who are non-obese. Use TZDs if the drug cannot control the target blood glucose, and you can add these TZDs to already sulfonylureas which this patient is taking. Though that means you can use TZDs as monotherapy in these individuals. You can use it in addition to metformin or sulfonylurea, or if the patient is taking both metformin and sulfonylurea, you can use the TZDs on top of it in order to achieve the glycemic control. One of the things which is important at this point in time is that there have been a lot of studies in the last few years which are, as a matter of fact, supporting and proving beyond much doubt that TZDs is going to be one of the drugs which is going to come up in the next few years of our clinical practice. There are more and more new drugs being introduced in this group, and more different receptors, PPAR receptors, are identified, and those drugs which are going to be affecting the different type of PPAR receptors can be a part of our TZD strategy that we are going to go for. I thought I'll just mention these two names because another couple of years these will be the two names which you will be listening more and more. One of them is rimonabant. It's a weight loss agent. Now this weight loss agent has got a hypoglycemic effect by tackling with insulin resistance. So it is going to give two different advantages in a type 2 diabetic who is obese. Not only that it will improve the glycemic control, but also it is going to improve the obesity of this individual. There are trials which are being carried out, and there are promising results about this drug. And finally, we have another derivative of PPAR drugs, and which is the muraglitazar. It is a combined PPAR alpha and gamma agent. It's also a very potent insulin sensitizer, and give yourself just 2 years and you will find that what is in the pipeline today can become one of the most important drugs in the management of type 2 patients. With this, I thank you very much all.